Hi, everyone. Thank you for joining us today to our webinar. I think it will take like 2 or 3 minutes. We'll let everyone get in, and then we can introduce our webinar today and the panelists. And of course, if you have some technical issues, please let us know by chat. And that's it, I think. So let's take another 1 or 2 minutes, and then we're going to start. Okay, everyone, nice to have you here today. I'm very, very honored to take part in this webinar today about the fundamentals of transgender medicine in the cooperation with the Centers of Transgender Medicine and Surgery at Mount Sinai Hospital in New York. My name is Roy, although it's written David there, but it's not David. And I'm the LGBT Medicine Fellow at Mount Sinai nowadays, but originally, of course, I'm from Tel Aviv. I'm an infectious diseases physician, and I'm a partner in the LGBT clinic in Tel Aviv center, in the Tel Aviv Gay Center. We brought you today really the best speakers of one of the leading centers for gender affirmation and transgender medicine. And I really hope you will benefit from all the lectures today. And I hope it will be the start of a new thing of cooperation of us with the Mount Sinai Hospital. And I feel that if there wouldn't be any technical issues, it would be great. And with that, I want to just start by introducing, first of all, for a few words, the head of the Israeli LGBT Society, Dr. Gal Wagner, and he will give some words, and we will continue with the lectures later on. So Dr. Wagner, can you hear? And I hope you can just join us.
Yeah, still no technical issues, but okay. So hello everyone. I would like to talk briefly about the LGBT Medical Association. Thank you first of all to Roy for organizing all this webinar. Thank you to the Mount Sinai staff, to Dr. Tamar Reisman and Dr. Jevsky for being here with us and teaching us. Also, we are actually summarizing 2020 for the Israeli LGBT Medical Society. And I will go briefly about what he did this year. I looked for that yesterday. We have 200 members in our society. Half of them are physicians, half of our paramedical staff. We had an election for the new board in the beginning of this year. It was very hard year to work with. So the first 6 months were Corona working only, but this is our new board. Myself, Roy Zucker, which is the secretary, Dr. Oleg Davidson, Dr. Adar Amir, and Dr. Ruth Goffen. And I will mention also Dr. Yitzig Levy, which is in our monitoring board, but takes very dominant part in our works. The LGBT Medical Association have a few goals, and the slides are in Hebrew, but I will try to talk in English. So I will talk about these 6 goals and what we did about it this year. So the first goal is expanding the knowledge of LGBT medicine in the medical society in order to optimize the treatment for LGBT people. So I'm happy to say that this year we launched the Israeli Studential Forum for LGBT Medicine. There are around 200 members now in this forum, which includes students for medicine and other medical professions. We started having lecture about LGBT medicine every month, and this forum is very active and doing a lot of stuff that I will talk a little bit later. In collaboration with the Hoshen organization, we're starting to build a lecture about LGBT medicine. In these lectures, we are trying together with the Studential Forum to talk with the medical faculties in order to enter these lectures into the curriculum of the medical training. We are in the final edge of building our online course of LGBT medicine. This course will contain around 8 short lectures, and our goal is that every physician in Israel, south, west, north, everywhere in Israel will be able to address this course and give his patients optimal treatment for these LGBT patients. The other goal of the LGBT society is to distribute the knowledge and fight LGBT phobia. What we did this year is started activate our Facebook page, which address medical stuff, but all the community, and we also update every time for new things regarding LGBT medicine. This year we did a lot of lectures from the south to the north of Israel. Luckily it was Zoom lectures, so it was much easier. And we did our first lecture about LGBT medicine in the Arabic language to the Israeli-Palestinian physician. The Israeli LGBT Medical Society will promote the health of the LGBT community and work with the community about that. So we're using our Facebook page to address the community and teach them about different kinds of health, like immunization, preventing STDs, drug use, and other stuff. We're also, another very important thing that we did is promoting the PrEP use in transgender women in collaboration with the Israeli AIDS Task Force and the Lola project. We built this brochure, and we are acting for this population. And the Israeli we will also try to act in order to influence the country regulations regarding LGBT health. So we took part in promoting a law against conversion therapy in the Israeli parliament. It was only the first call, and there is a lot of work to do, but we were proud to try and help promote this thing. We also, with the Israeli AIDS Task Force and the Aguda, try to update and improve the process of youth PEP with the Ministry of Health. We're also aimed to help and doing more researches regarding LGBT medicine. So in this studential forum, we are launching in 2 weeks the a group of for research, and we're trying to combine with physicians and researchers to medical students in order to do a lot of researches regarding LGBT medicine. And we also this year did a research about the life of people living with HIV and in the COVID area. Thank you for Dr. Itik Levy, which led this research, and I hope it will be out soon. Finally, the Israeli LGBT Medical Association will collaborate with Israeli organizations, and what we did a lot, and all the things that we did were only a part of our collaboration. And we're also aiming to collaborate with different kind of organizations and clinics around the world. And I think that this event will be a great beginning for that too. So I will end my short speech about and ask you everyone that you can renew or sign up to our society. Every member is our power. So if we are now 200 and we have the power to do stuff, if we'll be 300, 400, 500 people, physicians and paramedical staff, that will give us the power to do more and more and influence more in all the aspects of our work. So again, thank you for being here, and I hope we'll have an easier and a better year. Thank you again, Roy, for organizing everything. Looking forward to hear all this stuff.
Thank you, Gal. Thank you, Dr. Wagner. First of all, before we start, I want to say that if you have some questions, you can just address it on the chat you can see on the Zoom, and we will collect all the questions, and the ones that will be the most relevant, we can ask them at the end, and then we'll have the answers. If you can also say who is the question is to, that would be great. And with that, I'm very, very glad to start this session today. And I'm very honored to start with Professor Josh Safer from the Executive Director of the Mount Sinai Center for Transgender Medicine and Surgery, the CDMS. And he will talk today about gender-affirming hormone treatment strategies for transgender and non-binary people. So thank you, Dr. Safer, and let's start.
Excellent. Well, thank you, Roy, for inviting me. Thank you, your whole organization. Thank you, Dr. Wagner as well. Let me just dive right in. Let's see where we are here. Boom. Good. So what I want to do for the next, I guess, about 25 minutes or so is talk about how it is that we got where we are in establishment medicine, what the real, the framework shift is in terms of our thinking, and also talk about what the implications for our approaches, at least with regard to hormone care. And so my outline is, like I just said, looking at why there is this sea change in approach, let's say relative to 20 odd years ago, and then what is the, what are we really trying to accomplish with hormones, just thinking about it from kind of a medical or a medicine perspective. The terminology, for me, gender and sex, people try to define these things differently. They've become umbrella terms both. And so I'll be more specific. I think so when I'm referring to gender identity, I will say gender identity, and then other things like cisgender and transgender and gender non-binary. In English are adjectives and not nouns and not prefixes. And gender dysphoria is really the mental health term that at this point is, I think, on its way to obsolescence. When the ICD-11 comes out, it will be replaced with a sexual health term called gender incongruence, rather than obligating transgender people to have a mental health diagnosis for treatment. So when I'm thinking about how we got to where we are, I have to remember that it's not too long ago. And I think people are still in this mindset of thinking about being transgender as a mental health concern, where an individual is transgender needs to go find a mental health provider and more or less be tested or somehow convince that person that they're transgender. And then the process of finding medical interventions for people who are looking for them, whether that's hormones or surgeries, becomes this ad hoc process where people who might be supportive would be enlisted for that. And what really happened over the past, I'd say, it's a decade or so, is this shift from thinking of gender identity as being perhaps something environmental, what you were told, or a societal construct or a passive response to anatomy, to the paradigm shift to thinking of this as something that is hardwired in your brain. You have a sex identity. It's that part of your brain that lets you know what sex you are, and therefore it's part of your sex biology, it turns out. And the data for this kind of fits into, from my perspective, 4 buckets, and I'll go through them pretty quickly. And to me, the buckets are in order of how convincing I find them. We'll see how much others agree. But the first is historical attempts to manipulate gender identity among intersex people. And the most illustrative paper on the subject, in my opinion, is an old New England Journal article from maybe about 15 years ago, where individuals with something called cholecystrophy had to have a fair amount of GU and GI surgery. And the result was that because a vaginoplasty, or making a vagina, is easier than a phalloplasty in terms of the technical elements, the determination is made to do that as the default. And so the relevant kids here are all of the XY chromosome individuals who might have otherwise, for the most part, been predicted to have male gender identity, all of whom were offered vaginoplasty and to be raised as girls, or shall I say their parents are offered, because the concept was gender identity could be manipulated. And if it could be manipulated, you want to begin right away at birth and really kind of brainwash the individual from the get-go. Don't even tell them about their medical history. And what happened with these, the program at Johns Hopkins is they're a bit of a center. They had about 16 kids in the circumstance. And what they observed is, after several of these kids in junior high school being raised as girls, not being told their medical history, told the physicians, the medical team, that they were actually boys, they turned around and investigated all of the kids in this circumstance and found that all of the kids who knew their medical history by the time they wrote the paper, all of these XY individuals reported male gender identity. And in fact, the only ones who were still reporting female gender identity were ones who were not aware of the whole treatment program. There are several other kinds of series along those lines, but the bottom line is our failure to manipulate gender identity in probably the most aggressive approach that we've ever had is the bottom line there. The second kind of category of data, I would say, are just simply twin studies. It's very superficial data. It's simply looking at case reports, and the situation is this: that when we have transgender people who have twins, if the twin is fraternal, not identical, whether they're same sex or opposite sex, in all the case reports in the literature, the twin is not transgender, similar to other sibling pairs. However, when the when it's a case with an identical twin, then there's a 40% concordance. That is, there's a 40% chance that the identical twin is also transgender. Just fairly simple here. The closer the DNA, the more likely that both are transgender, suggesting there's something there in the DNA. The idea being that on all of these cases, these kids are raised together in similar environments. The only category of data to date that even begins to get at a potential for mechanism explanation for some transgender people, for some gender identity, I mean to say, is in utero androgen exposure data. And there are the two extremes of that are individuals with an entity called virilizing congenital adrenal hyperplasia, XX individuals, so female chromosome individuals, maybe while most of them have female gender identity as predicted, about 5% maybe, depending upon the survey that you read, have male gender identity, 5% being a far higher percentage of XX individuals with male gender identity than you would see in the general population, if you believe some of the surveys that are out there where they suggest that anywhere from 0.5%, 2/3%, or maybe even a full percent of people are transgender, but certainly not 5%. And on the flip side of things, individuals who are XY with complete androgen insensitivity syndrome, which means that the receptors for testosterone are completely not responsive to androgen, to testosterone specifically. Those individuals have female external genitalia that are visible at birth, and as they hit puberty, they have breast development, but because they don't have the other genetic components that are typically associated with being female, they don't have a uterus or ovaries, and then they come to attention when they don't menstruate. But the important point relative to gender identity is these individuals overwhelmingly have female gender identity. And it just suggests that at least for some people, you need to be able to be responsive to testosterone to some degree in order to have male gender identity. And maybe that's a bit of a mechanistic observation. And then the last category are attempts to find brain anatomy associations with gender identity. There are some pretty pictures, really, because I'm just going to glossing over this relatively quickly. I don't have all the pictures up there, but the best picture is still, in my view, the original one way back from the 1990s, histologic slides showing that there are regions of the brain that can be associated with gender identity as opposed to with hormone status or with other elements of other visible anatomical elements. So if this is biology, what do we need to know? And that's where I want to spend the next, the rest of this little presentation, which is talking about what our strategies are for giving people hormones and how that's shifted. So first of all, if we're dealing with something that's biological, the whole idea that we start off with a mental health approach, trying to learn if people are really transgender, kind of goes away. Really, we just want to know if people know what their gender identity is and if they are reliable enough reporters that we can trust them. And so somebody who doesn't have a mental health explanation for not being able to articulate their gender identity, who is old enough to know what gender identity even means, so that could be adolescents, I mean, it even includes some younger children, but certainly adolescents and certainly adults, simply go to a primary care provider and talk about what it is that they're interested in doing in terms of reconciling the fact that their external anatomy is not aligned with their gender identity. And if there is mental health support, it's going to be maybe thinking through what it is they want to do about it, but not necessarily convincing somebody that they're transgender. And the other specialists, like endocrinologists helping with hormones and surgeons, et cetera, do so in a much more conventional medical framework. When we're thinking about then the interventions, we kind of have to recognize that it's still the case that transgender people present as adults or in late adolescence for the most part. And there's no test, there's no scan. And so is this relatively late presentation the result of ability to articulate your gender identity, your awareness? Do you need the vocabulary? Do you need to understand what the concept even is? Is it that some kids are simply trying to conform to societal's expectations that they be cisgender, that they not be transgender, and it takes a while for them to overcome what's happening? None of this is known, but that is the circumstance. And the other thing that to think about a little bit as I'm going through these next bits are that fertility is still addressed very much in an ad hoc fashion. If we get to the future state where we're appropriately respectful of transgender people, then it's still the case that our hormone treatments and for sure some of our surgical treatments are going to interfere with fertility. So when we're thinking about our strategy, I think this picture helps. It's a picture of identical twins. They're XY male chromosome. The one on the left is the one who's transgender. She's only received puberty blockers as of the time that this picture is taken. And so really it kind of illustrates the fact that a female, typically female puberty is somewhat linear, but contrast her to the brother, the non-transgender, the cisgender one on your right, who has had maybe a year or so of testosterone. This picture is taken right before their 15th birthday, and you just see all the impacts of testosterone that might be for a trans feminine person be things that need to be addressed. And so you expect the hair over the lip, but observe the midline structures like the nose being larger, the squaring of the mandible, the enlarged larynx, which means the voice is likely deepening already, and the SEM muscles on the sides of the neck, this being a known pair. He's not like lifting weights with his head or anything. That's a testosterone consequence. And then the other way to envision this is to think about the fact that total testosterone levels between men and women are really the big difference hormonally, with estrogen levels being somewhat overlapping depending upon or assuming that estradiol, which is all that we actually measure, is a reasonable surrogate for that. And so what we're doing strategically for transgender people when we're manipulating hormones is we're adding testosterone to transgender men, and we're suppressing testosterone for transgender women. And if I'm going to kind of summarize a little bit, and then I'll go into a little more detail, what that means strategically, well, a handful of things. If we're starting with kids who are prepubescent, there is no treatment at all medically. But one thing that's a concern to some families is, what if I allow my somewhat gender expansive child to dress or act as they report their gender identity to be? Will they brainwash themselves into being transgender? And the short answer to that is external societal pressure was unable to change gender identity in intersex individuals in the past. And so the likelihood that your child or that your child's friends will brainwash your child seems pretty remote for something that should be a biological entity. And people can feel pretty safe being respectful of their kids, and their kids will do what they want. And if it really is just a stage, they'll shift how they want to shift. And if they really are transgender and the kids are already clear on their gender identity, then you're only being respectful to them. There are, of course, some kids who are clearly articulating either whether they're really transgender or whether it is that they really want to do anything about it long term. And so kind of at the next stage, as kids reach puberty, we use puberty blockers, which are more or less reversible, and that buys more time to discuss what the long-term hormone plan ought to be as a child ages and becomes more mature. There's fear of bone health, of course, and so beginning puberty blockers is not an end in and of itself. It's an opportunity to be more thoughtful and methodical, and know that you're going to have to make some choices for good bone health, either to bring in exogenous hormones that fit with gender identity, or to allow the natural puberty to occur with the consequences of that hormonal environment and its impact on the body. For trans masculine individuals, for trans men, the treatment is very straightforward. All we're doing is adding testosterone, and we use the same exact medications that we do for any individual who requires more testosterone. For the purpose of this talk, I'm not getting into any of the nitty gritty. It's however, whether it's be injections or gels or whatever seems appropriate, and bringing those levels to conventional, what we consider to be physiologic male levels for the most part. For transgender women, things are a little more complicated because what we're doing is blocking testosterone. This is where people often get confused. The main agent we use to block testosterone is estrogen, serving a dual role. It not only acts centrally to suppress testosterone, but because we need sex hormones for good bone health, it acts as that necessary sex steroid that you want circulating. And frankly, we would just use large doses of estrogens and be done with it if it weren't for the fact that we're concerned about thrombosis concerns with estrogens. And we think that, and our thoughts that it's connected to dose. In fact, this is a list of the medical risks associated with sex hormone therapy from the Endocrine Society guidelines from 2017. And the very tippy top thing, it's the thing we know that we have the best established, is a fear of thromboembolic disease with estrogens. And about the best study on the subject from Annals of Internal Medicine from a couple of years ago, looking at about 4,000 to 5,000 transgender people versus just shy of 100,000 cisgender people, shows excess events no matter how you control. So at 2 years, anywhere from 3 to 4 excess events thrombotic events per 100,000 people among the transgender individuals, and over time it gets even worse, 14 to 17 excess events. So it does seem to be the case that when you add exogenous estrogens for transgender people, you are going to see a few more thrombotic events. A big report from the British Medical Journal from it's 2 winters ago. You don't have to read the detail of it. It's a meta-analysis, not transgender specific, just looking at estrogens, and just look at the pattern on the far right. No matter what, and the point is, no matter what estrogen product is used, as you increase the dose, the purple lines are simply the risk of thrombotic events. They move more and more to the right, more and more chance of thrombotic events. In addition, an additional take-home message is that when they added progestins, almost no matter what the product, even more thrombotic events. And then one little sub point is that, again, no matter what the product, if there was a transdermal version, there would be fewer thrombotic events. And we can talk about the detail of that, whether that's what's considered to be a first pass through the liver effect, or whether it's just that these gels are less efficient and these people got less product. And it's really just an extension of the dose response curve, so that there are fewer events when they got less across their skin. But bottom line is at least that dose connection. But very important when we're thinking about this is what's the absolute risk? And so the one prospective study in transgender women, just shy of 700 women over about a 2-year period, taking estradiol pills, or taking pills orally, came up with 1 recorded event in the entire crowd. So the overall risk is quite small, even if we know that it's true. And something that we've seen at Mount Sinai, actually, which just was accepted for publication right before the new year, relates to the fact that one of the anxieties for our transgender people who are looking for surgeries is because that's another clot risk period, that maybe they should hold their estrogens and not have a double risk. But what we observed at Mount Sinai is when we're appropriately aggressive with our DVT prophylaxis protocols for our patients having surgery, that when we were holding estrogens in the perioperative period with about 300 or so patients, we had only 1 person who actually had a thrombotic event. So good news there. But when we allowed patients to take their estrogens right through and didn't even bother stopping them and just used our DVT prophylaxis protocols, similarly with about 300 odd patients in this situation, we didn't have any recorded events. And so there didn't seem to be any, we don't see any gain to having these people hold the estrogens. That is, people are overly fearful of estrogen in these contexts. And the last little piece, just talking about strategies, I'm just going to talk about surgical options from a medicine perspective. And I really want to make 2 points. So for the transmasculine individuals, for transgender men, chest reconstruction is very popular. Being able to wear a shirt and be in public and appear according to gender identity being a high priority. But notably, the thinking about those intersex kids where the choices were made because of our technical skills with different surgeries, that has the fact that our ability to create male genitalia is more modest than female genitalia from a technical perspective does have implications. And the reality is, fewer than 10% of transgender men are choosing to have these surgeries. And so that has downstream consequences when you think about monitoring them later, that they haven't had those surgeries for the most part. And then the one point I want to make for trans feminine people, for transgender women, is that while we're very genital focused, and the vaginoplasties are more effective surgeries, and so more of transgender women do choose those surgeries, for many transgender women, the surgeries that affect their appearance to the general public is the higher priority, including facial feminization and breast augmentation, affecting their comfort walking around in society, as well as their safety with what's with their genitals being something that's just between them and their intimate others. For many payers, that we look at this through a cisgender lens, and a genital reconstruction surgery is something that would be required, but a facial feminization surgery is something that would be considered cosmetic. But when we're dealing with transgender people, they're all required. And for many transgender women, those facial feminization surgeries can be the higher priority, and just something to consider. And I think, and those are my pieces. So thank you very much for your attention.
Thank you very much, Dr. Safer. It was a great talk. And with that, I'm going to continue and I'm really honored to introduce Dr. Tamar Reisman. She's an assistant professor of endocrinology in the Mount Sinai Center for Transgender Medicine also. And with that, I'm also reminding you that if you have some questions also to Dr. Safer, you can just add it up in the chat box in the questions and answers, and we will help you figuring it out later. And Dr. Reisman will talk today about the transgender breast, developmental, aesthetic, and epidemiological considerations. So thank you, Dr. Reisman, for being with us, and let's start.
All right. Thank you so much, Dr. Zucker and Wagner. I'm excited to share my presentation. My name's Tamar Reisman. I am an assistant professor of medicine at Mount Sinai, specifically in the endocrine department. And today we're going to be talking about breasts. So generally speaking, breast development, and then more specifically, the transgender breast. So we'll talk a little bit about development, and again, transgender breast development, and then moving on a bit to discuss breast cancer and how that affects transgender women. So the earliest breast development actually starts very early, around 4 to 6 weeks into fetal development. And it's actually hormone independent, and it is similar regardless of sex. And what happens is you get the development of these mammary progenitor cells, and they form these anterior mammary crests that run along both sides of the body. And then over time, these mammary crests involute, leaving behind 2 sort of primordial mammary buds. And these are typically paired, but we can see in 1 second what happens when they're not paired. And these mammary buds sort of lay the groundwork for later breast development that is hormone dependent at puberty. But at this stage, XX, XY both develop the same sort of structures that allow hypothetically for breast development later on. So what happens if those mammary crests don't completely involute? So you can get a situation like this called polythelia, supernumerary nipples that typically occur somewhere along the mammary, where the mammary crests used to be. Or you could even get something like this, which is ectopic breast tissue. So usually that occurs in the axillary area, but again, hypothetically, they could occur anywhere along the mammary crests. So what happens at puberty? So we use the word puberty kind of colloquially, but really what we're talking about is thelarchy, which is breast development at adolescence. And usually this occurs around age 8 to age 13. We recognize now that these are numbers that come from American data, but when thelarchy hits does depend on your background to some extent. So that might be different in Israel. And we think of breast development in terms of Tanner staging. So Tanner stage 1 is pre-development. Tanner stage 2 represents the earliest breast tissue development. And Tanner stage 5 represents the completion of adult breast development. And I say that kind of in quotations because breast tissue actually continues to change throughout the lifespan, but we'll kind of hold off on discussing that for a moment. So this journey between Tanner stage 2 and Tanner stage 5 takes on average of 4 to 5 years to occur. So what does the Tanner stage 5 breast look like? So we have large ducts which drain at the nipple. And these ducts branch and branch and branch until they reach the TDLUs, the terminal ductal lobular unit. And these are acini that produce milk during breastfeeding. These glandular structures are surrounded by a fibrous and fatty supportive tissue called the stroma. And that's largely responsible for creating the shape of the breast. So how do we get here? How do we get to a Tanner stage 5 breast? So primarily estrogen. So estrogen is by far the most important hormonal influence when it comes to breast development. It's important for taking these primordial breast structures that occur during fetal development and stimulating them to get to their to get to the point where breastfeeding becomes possible. It's also important for fat deposition in the stroma. And we know this because when you take mice and you give them tamoxifen and you block their estrogen, you don't see the ductal growth and you don't see breast development. As a supporting player, there is progesterone. So that is not really necessary for size, and it's not really necessary for early ductal development. But if a patient is going to breastfeed, you need progesterone because it helps the ductal system mature, and it's important for lobulo-alveolar development and getting all the structures ready that allow for breastfeeding. As a supportive player, you have prolactin. So prolactin works indirectly with progesterone, helping mature the ductal system. And again, we know this because in mice without prolactin, they do not develop the mature ductal structures that allow for breastfeeding. So in transgender women, breast development is pretty similar to cisgender thelarchy at adolescence. It is hormonal. It's the result of hormones, but exogenous rather than endogenous. So how do we give this exogenous estrogen? So typically we recommend estradiol, 17-beta estradiol, rather than what's found in birth control pills, which is ethinyl estradiol, rather than conjugated estrogens like Premarin. And 17-beta estradiol comes in a patch, it comes in a pill, it comes in an injection. We won't go into the pros and cons of each because that's its own talk. And like Dr. Safer mentioned, we pair this with an anti-androgen. So in the US, that's usually spironolactone. Transgender women, as breast tissue develops, go through similar Tanner stages compared to thelarchy in cisgender adolescents, and you can see them clinically. You can actually observe them radiographically. So you can see them on imaging. And if you were to look at these images, or if you were to do a biopsy and look at this tissue histologically, you would see that it's actually indistinguishable from that of cisgender women. So here's the million-dollar question, because it seems like this is what patients are really interested in, which is, why are some breasts bigger than others? And how do we get there? And the answer to that question is it's actually not the ductal system that varies from person to person. That's pretty similar actually from person to person. What differs is the stroma. So that can take up very, very different amounts of volume in different patients. And unfortunately, we don't know all that much about this and how this expansion in volume takes place. We know it's somewhat hormonally controlled because during puberty, you see an estrogen-dependent expansion in stromal volume. But that's not the whole story. Or maybe that's just the beginning of the story, because at some point, hormonal influences stop causing stromal volume expansion. And so the best example we have of this is in pregnancy. So during pregnancy, we see an estrogen explosion, and we see a subsequent expansion of the glandular components of the breast, but we really don't see much change in the breast stroma. And so, unfortunately, I don't really have an answer to the real question, which is, well, how do we help develop the biggest breast possible? If I had that answer, I'd be rich. All we know is what doesn't really help. And so, unfortunately, one of the things that doesn't really help is progesterone. So one of the rumors that we're constantly trying to combat in the clinical setting is patients want to take progesterone because they hear that it helps with breast size, and unfortunately it really doesn't. So when do we see breast growth in transgender women? So in cisgender women, again, patients usually go from Tanner stage 2 to 5 in 4 or 5 years. Unfortunately, we don't really have any breast growth studies in transgender women that last that long. What we do have is 2 studies that say 2 sort of different things. So Meyer and his team in 86 say that maximum breast growth occurs at 2 years of treatment. So in the United States, that has implication for breast augmentation surgery. We are able to have insurance provide that surgery at 2 years of treatment. Meanwhile, we have Block in 2018 who reported that development mostly occurs in the first 6 months of treatment. So that's the time of most robust breast growth. For whatever reason, it does seem as though transgender women have smaller breast size on average compared to cisgender women, but unfortunately, that is complicated by the fact that we don't have a really good handle on the size of cisgender breasts. So believe it or not, the data that we have about the average volume of cisgender breasts tends to come from bra company data. And a lot of those studies are very specific. So for example, like they'll go to a college campus and get their data from college students. So obviously, so that tends to exclude older women, that tends to exclude pregnant or breastfeeding women. Depending on where you get your data from, that might even, those women might be thinner on average compared to the general population. So thinner women tend to have less adipose accumulation in the stroma. So we actually really don't have a good handle on cis women breast volume. So obviously it's hard to make a comparison, but we know a few things. So we know, unfortunately, again, estrogen type doesn't seem to contribute to breast volume. Estrogen dose doesn't really predict breast growth. And then all these little tricks that people have tried to maximize breast growth, like slow upward titration of estrogen or avoidance of spironolactone or adding progesterone, again, doesn't help. So what we do know is that many transgender women choose to seek breast augmentation at some point. And there are 3 separate European studies that come across the same number over and over again, which is 70%. So about 70% of transgender women seek out the surgery. So that may speak to the fact that breast growth is inadequate in our transgender patients. It may just speak to the fact that breast size is seen as an important marker of femininity. That's an important goal of many of our patients. So working in the CTMS and having a large patient population, I do hear things, and I've heard some questions from patients. So there tend to be certain ideas that are floating around. So I've heard from multiple different patients that transgender women have pointy breasts, that they have tube-shaped breasts, that they have conical breasts. and that by being on the right hormone regimen, you can prevent shape abnormalities. So for example, I need progesterone because I'd like to have rounder breasts. And so I was curious, just having heard this time and time again, whether there was any truth to these statements. And so the closest thing I could find was this. So this is actually a cisgender woman, but this is an example of what's called a tuberous breast deformity. And so what you see is a constriction of supportive tissue with breast tissue extruding through that constricted breast base. Sorry. So basically, long story short, there might be something to this. So the reported rate in teeny tiny studies of transgender breasts show an increased incidence compared to cisgender women, but overall, it just is seen across the general population. So cisgender men with gynecomastia have this problem, cisgender women have this problem, transgender women have this problem. So it doesn't really appear to be that there's anything unique to breast shape or development in transgender women compared to cisgender women when it comes to shape and morphology. So, okay, so kind of like moving along a little bit. So we'll skip to breast cancer. So what we know about breast cancer incidence is, for whatever reason, the rate in cisgender women is much higher than the rate in transgender women. And so one of the questions we have is, why is there such a huge discrepancy? And we have a couple of possible explanations. So the first is a bit of a bummer, which is there isn't actually any difference in incidence. We're just not really picking up on these cases. So we're either not picking up on the cases because these patients become lost to medical care, or because it can sometimes, again, in the United States, I'm not sure what this story is in Israel, it can become difficult to classify which patients are transgender, and some of these patients who develop breast cancer may not be recorded as such. Another possible explanation is a shorter overall lifetime exposure to estrogen. So we know from studies in cisgender women that breast cancer risk goes up with lifetime cumulative dose of estrogen. So cisgender women who have menarche earlier or hit menopause later and have a longer exposure to estrogen tend to have increased risk of breast cancer. Other possible factors, again, as if we needed another reason to avoid progesterone. So many transgender women are not treated with progesterone. We know from the Women's Health Initiative study in menopausal cisgender women that estrogen plus progesterone causes higher risk of breast cancer compared to estrogen alone. And last but not least, testosterone may have a protective effect. So if a transgender woman starts her transition after puberty and is exposed to high levels of testosterone for several years, it's possible that that exposure has a protective effect. There are some laboratory studies that show that testosterone has an anti-proliferative and apoptotic effect on breast tissue. So how do we screen transgender women for breast cancer? It sort of depends who you ask. So every organization has a bit of a different set of guidelines. So usually you start at age 40, you start at age 50. You do it every year, you do it every 2 years. So our general recommendation is you wait until 5 years of hormone therapy, and then you follow whatever whatever organization's recommendations. But starting at 50. Okay. So in general, in cisgender women, our gold standard imaging modality is mammogram. It is the only imaging modality that has been proven to lower mortality from breast cancer. But the reason mammograms are so great at detecting masses in older women is because over time, breast tissue becomes more and more fibrotic, less fatty, less dense, and that sort of allows mammograms to see masses very well. So in younger patients who have denser breasts, ultrasound screening is actually recommended in addition to mammograms, because mammograms might miss some masses with in patients with denser breast tissue. So this could potentially have implications for transgender women, because transgender women probably have denser breast tissue compared to their age-matched peers. And so there's one Belgian study that sort of looks at this specifically and came up with this number, 60%. So 60% of transgender women have dense breast tissue. So that may have implications in terms of choice of imaging modality. For right now, we're still saying mammograms, but basically keep your eyes peeled, because that can potentially change with more data. Other things to consider when selecting an imaging modality, so breast augmentation. So like we mentioned in a prior slide, about 70% of patients choose to undergo breast augmentation. Breast implants themselves are not actually associated with breast cancer, meaning it doesn't cause cancer stemming from breast tissue, but there are certain implants, so textured implants, that are associated with breast implant associated anaplastic large cell lymphoma. So it's a type of non-Hodgkin's T-cell lymphoma. And so in the US, there was in 2019 a voluntary recall. So hopefully we're using these implants less in the future because of this increased risk, although it's worth mentioning that this is still a very, very rare cancer, and probably most of our patients don't have to worry. What we have to worry about more is the idea that implants might obscure masses. So any patient, cis or trans, if they are getting a mammogram, they should be telling their technicians that they have had implants, because what the technician can do if a patient has an implant is they can do what's called the Eklund technique, where the implant is displaced posteriorly and sort of moved out of the way in order to better visualize the breast tissue without the implant obscuring it. So unfortunately, in a lot of our older patients, rather than having traditional breast augmentation with implants, sometimes patients inject other substances into their breasts for breast augmentation. So free silicone, paraffins, other substances. And again, it's really important for patients who have had those procedures to let their mammogram center know, because it can affect visualization of potential masses. So this is an example of a patient with granulomas from free silicone injection. It's creating what's called a snowstorm appearance, where you get all these little granulomas that A, can be mistaken for cancer, or B, can obscure masses. So hopefully moving forward with more availability of breast augmentation, patients will be moving away from these DIY kind of procedures. So that is the end of my 20 minutes. So just to recap quickly, so pre-pubertal breast development is actually hormone independent, and it's indistinguishable between sexes. Further, breast development is hormone dependent, and we can induce it by treating transgender women with feminizing hormone therapy. But unfortunately, right now, we still don't quite know how to maximize breast growth and patient satisfaction. And so we need more data. And more importantly, we need more data when it comes to breast cancer development and breast cancer screening so that we can provide the best possible guidance for patients. So thank you so much. Again, I'm Tamar Reisman. Please feel free to email me if you have any questions.
Thank you very much, Dr. Reisman. That was a great talk. We have some questions for later on also, so stay with us. Our next speaker will talk about a very hot topic these days, the approach to genderqueer, gender non-conforming, and gender non-binary people. And I'm really glad to introduce Dr. Lauren Rajajewski. She's the clinical program manager for the Center of Transgender Medicine and Surgery. And with that, I'm giving you the microphone.
Hi, thank you. I hope you can hear me okay. As I fumble through sharing my, did you let me share my desktop or no? It doesn't seem like it's allowing me to. Tech people, can you hear me?
I can hear you, yeah.
Okay, I can't seem to share my,
Just a second, please.
Okay, well, while you're doing that, I'll just introduce myself. My name is Lauren Rajewski. I am the clinical program manager. I'm also the main primary care provider at the Center for Transgender Medicine and Surgery at Mount Sinai. I understand that there is not an equivalent role for the nurse practitioner in Israel, so I will briefly touch upon my role and training. Nurse practitioners are RNs that go on to receive doctoral level training in various specialties, usually in primary care, but sometimes in mental health or women's health, and then assume some of the roles traditionally performed by physicians. And I think what makes us particularly well suited for primary care is that we do retain the sort of nursing approach to care, which is a very collaborative and coaching type of care. And this comes into play particularly with this patient population who, as we'll see, often need a lot of significant, we say high touch sometimes, but coaching or wayfinding through sometimes something that can be a rather difficult process. So I'm going to try to share my desktop again, and let's see if it works. It is still not working. I could use some tech support on how to share the desktop because it doesn't seem to be doing it.
Okay, so it's Sharon from the control room. Please press the share screen button.
I did that.
Okay, now choose the app. Do you want to share the PowerPoint or the?
Oh, I see. Okay, got it. Okay, sorry. I'm not.
Okay.
It says permit Zoom. Yeah, permit. Okay. Okay, I did that.
And now please press share in the right bottom of the pop-up screen.
It's not here. Okay. It's not coming.
Okay, let's do the process again. Please press the share screen button, the green share screen button.
On the bottom.
Okay, on the bottom, please press it. And now in the pop-up screen, please choose the app do you want to share, the PowerPoint.
Yes, I did that.
Okay, and press share in the right side of in the right bottom side of the pop-up screen.
When I do that, it says permit Zoom to access my thing, and then it gives me an option. Yeah.
Oh, okay, maybe it's because you do it from your browser and not from the app of the Zoom.
Yes, I did that from the browser. That's
okay,
correct.
so it's I'm sorry, but you can't if you do it from your browser, it's not you need to download the app to share the screen.
Oh, okay. Well, that's something we didn't identify. Well, there's nothing special about my presentation that you need to see, really. There are not a lot of graphs or so forth, so we can just proceed through what I have to speak about. And actually, this is good because what I think this illustrates, this little problem, is the kinds of things that come up for us in primary care, which is that every day is different, and we just never know what we're going to get. And especially when it comes to the trans population. And so what I wanted to do was to break down the presentation into just some basic parcels, if you will. And these specifically are the characteristics of the population, and then subsequently the types of risks that they face as a result of their unique characteristics. And then how do we combat against those risks by certain types of screenings? And then also I do want to touch on some exam specifics. And I thank Dr. Reisman for covering so extensively on the breast screening, because it really is something that is quite important. And we will touch on that a little bit as well. So moving on to the population. Now, of course, this will vary to some extent by country and by culture, but as these numbers are for the United States. But I think that generally speaking, at least for the Western world, what I'm about to speak about sort of applies, which is that this particular population experiences a disproportionately large burden of minority stress. And in the United States, from a landmark study that was done, it's 5 years old now, but it's still, I think, one of the best sources that we have. We learned that 41% of transgender women have attempted suicide in their life. 35% have been assaulted. So think about that more have attempted suicide than have been even assaulted, and the number for the assault is quite high. 19% of this population has experienced homelessness, and 78% report harassment. And then we could go on and on with these numbers, and there are some really startling numbers from the healthcare environment as well. And really what this all builds up to and sort of informs is the significant burden of stress, which we call minority stress, and the resultant PTSD, depression, anxiety, home insecurity, things like that. And those, you cannot provide primary care for this population without taking these things into consideration. In fact, it is the most important aspect of the primary care. As a general rule, the primary care for the trans population is going to be essentially the same as the regular general population. However, you really do need to take into consideration these population-specific nuances and use them to tailor how you'll approach the population. And jumping on to the risks, I want to mention how important it is to build a therapeutic alliance with patients. So we know from studies that people experience significant amount of marginalization and often even at the hands of primary care providers. So you can imagine somebody that maybe has come to your office that day, been harassed on the street, perhaps has been in the past fired from their job because they came out as trans, and maybe has just gotten into a fight with the person they're living with, and maybe is a tenuous living situation, and then they arrive at your office and they're brand new to you. Is that person going to be on edge? There's a good chance that they might. Will they have some lower threshold to any kind of adversity, like a problem at the front desk, they will. And so you need to be prepared for those things. So moving on to the sort of specific risks that, you know, I think of as almost resultant or resulting from some of the marginalization and burden that this patient population carries. We see significantly higher rates of HIV infection. The rate of HIV infection is about, in transgender women, is about 3 times the national US population. So the fastest growing percentage of the population who are being newly diagnosed with HIV are transgender women. And to break that down further, the largest percentage of those transgender women are women of color, Black, African American, and Latino and Latina, although the numbers definitely are skewing very heavily towards the trans women. So naturally, HIV infection has a top on your list of things to think about as you proceed through the primary care spectrum and your regular visits. We'll go back to how this relates to the recommendations we'll make, but I want to address some of the other specific risks that you'll see in this population first. The biggest one being what I touched upon earlier, which is the mental health burden. We know that about 44% of trans women have reported suicide attempts in their lifetime. And to put that into perspective, the last numbers I saw for the United States, at least, was about 5%. So for the general population. So we're talking an order of magnitude greater attempted suicide rates in this population. And that just goes to show you that the PTSD and other mental health burdens that they're carrying with them affect their overall health status. 11% of trans women have reported attempting suicide after being rejected by a family member. So, you know, that's a situation that you can imagine might occur when they come out. So if you are, you know, working with a woman that has not yet come out, you might need to mobilize resources in advance of that, particularly if they have any history of depression or anxiety. And then 13% have also reported that when they were denied any type of treatment in the past, that they attempted suicide. So that's a staggering number. You think about it, 13%. So, you know, if 10 women walk into your office, you know, if they perceive any type of denial of care, and Dr. Reisman touched upon, for instance, not choosing to prescribe or not, you know, not really wanting to prescribe progesterone for breast development, that can be perceived as a denial of care and somebody primed to, you know, to expect rejection. And that can result in a suicide attempt rate of 13%. So, but I'm not telling this to get people concerned or worried. What I am, the reason why I'm bringing it up is because how you will provide care for this population will be different as a result of knowing these things. That, you know, when you're approaching difficult subjects, particularly things that might put a barrier in the place of somebody's path, that might be perceived in a way that is it seems to the patient as though or a denial of their existence or a denial of their gender identity, and it's being informed by all these past experiences. So now moving on, so and then these are the 2 biggest risks I've chosen to identify. There are some others, but these are the ones that really come up time and time and time again. And now let's talk about how do we mitigate these risks along with just the general stuff that you would do in all of your primary care circumstances. So that moves on to our screening. So screening for this population in the primary care setting is going to be all the usual stuff that you would do for the age appropriate. And you have to target it based on the organs that that particular person has. So if they have a uterus, then they need pap smears based on the guidelines, which most people are familiar with, would be either 3 or 5 years with negative pap and HPV, depending on age. In addition, to those general health screenings, every person that walks into the clinic every single time should be receiving a PHQ-9 or some validated form of depression screening. They may not be willing to tell you that they're having trouble. They may be worried that it might deny them from getting their testosterone or their estrogen. They may not be able to put into words what they're experiencing, but it's very important. And even though it's a very simple tool, it is useful to identify potential cases and also to open up a dialogue about those things and what we can do. So as far as the PHQ-9 goes, what we do in our clinic is that the nurses or the intake personnel, they administer a PHQ-2, which is just an abbreviated version. And if that screen's positive, they let us know, and then we administer the full PHQ-9. Now, most of our patients actually are already engaged in mental health, but this still brings up a conversation. What's changed in your, in your life? How is your housing situation? Currently with COVID, many people are now experiencing joblessness, and this is at a much greater rate than the general population, because this population had a tenuous hold on it to begin with often. So bringing up these things and then talking about, hey, I am concerned, and the reason why I ask about these things is because, and I share the numbers with them, like trans women have a much higher rate of depression and even, unfortunately, things like self-harm than the general population. And then I go on, and this helps to build the therapeutic alliance. I go on to say, and this isn't your fault. This is the aggregate of so many years of marginalization. And I just touched on some points. I had a patient who was told that she couldn't be, that she was dismissed from care because she was trans. And I just list a few things. And what that does is it approaches the subject in a way that I think is accessible to the patient. And then it also lets them know that you are aware of what they're going through. Say, I had a patient that was that lost their housing, and I had this and I had that, and all these things relate. So I bring those things up, and then I focus it back around to the actual depression to say, it really, this is a part and parcel of trans care. This is something that is hand in hand with gender dysphoria and the experience of being a trans person, and that we really ought to treat this, because you won't be relieved from the dysphoria in entirety and be able to have a fulfilling, complete, healthy life if we don't address this. And so I use the opportunity to bring that up. So I find that the PHQ-9 is a quite helpful tool, even though it's quite simple. And then the other thing that I always offer every single visit is HIV and STD screening. And really, you would be amiss if you did not do this. This is something, this patient population has got a much higher rate of HIV, as I covered, but also a very high rate of sexually transmitted infections. So I offer it every visit, and I don't, while I like to provide patient-centered care, if patients go, no, I haven't even been sexually active, I usually at least push back one time on it, because very frequently what they perceive as not sexually active and what I perceive are two different things. So they may say, well, no, I haven't had anal sex, and but then you go on, and it's like, well, I have still had sex with my partner, but we're exclusive. And of course, we all know how that goes. Or they haven't had receptive intercourse of some type in their anus or genitals, but they have provided oral sex to somebody. So I really just try to make sure, like, you haven't had any sex at all, like nobody's body part was in you, touching you, anything. And then of course, if they decline, that's fine. Now for patients that are at any risk, this is the opportunity when we offer the screening then to go on to say the rates of HIV for trans women especially, but for all people in this community are much, much higher. And I absolutely you know, I say, as far as I'm concerned, anybody that's sexually active in this city, and especially the trans population, they should be on PrEP if they're not HIV positive. So I have that discussion. So I did want to touch, since I'm on the topic of PrEP, something that's very important, which is that you never, the organs that you'll be dealing with here are different than the standard organs. So the typical PrEP patient is like a gay man who, you kind of know the whole story. Well, you may have a trans woman who is still using her penis, or you may have a trans guy that is still having receptive vaginal sex, or you may have a trans woman with a neovagina, and the way you administer and advise on PrEP will be slightly different. You know, on-demand PrEP has become a much more common thing. And I don't generally like to advise it in our population because they tend to be so sexually active, but I think there are a smaller segment of people that might benefit from it. But it's important to keep in mind that it is not appropriate for people having vaginal sex, and that probably includes also neovaginas. We don't have very good data on that, but so people that, so a trans woman that maybe you previously knew as somebody with a penis who was using that penis penetratively, now is having receptive sex, they may have been accustomed to doing on-demand PrEP and that was fine. Now they have a vagina and they're getting receptive vaginal intercourse. On-demand is no longer appropriate. So on-demand has only been shown to be effective at the getting the tissue concentrations in receptive, in anal intercourse, essentially. So that's just something to think about. And it just, you know, some of the rules that we ordinarily kind of structure our day or our approach to patients around, they can be turned on their head a little bit. And it's worth noting, as far as regular screening goes, this brings me on to my next topic, in fact, that when you get on to doing your actual exams, they need to be organ focused. And so if somebody has breasts, you do the usual breast exams and the screening and so forth that's recommended. If they have a prostate, that should be examined based on the current guidelines. We won't go into that today. You can look those up, and there's a little bit of conjecture about when we should start these things, but nonetheless, if they have these organs, they need to get them screened. And when you approach these topics to patients, you know, you have to understand the trauma that they're coming with, the denial of care. They may not be very out in the community that they're even trans. And so approaching them and saying, oh, and by the way, you need a pap smear, be prepared for a pushback that might be more than just anxiety or stress, but might actually be that you're denying me care. Like it just, and it's a reflexive thing, but it's there. So you just always have to be able to dial it back, like, well, no, you know, that's actually not at all what it's about. In fact, it's the opposite. Denying care is when I don't ask about these things. I also like to, when we're doing the exam, use that opportunity to pay special attention to both screening and teaching of the patient about new organ systems that may be present for the patient. So one of the things that we very frequently find is a woman has had a vaginoplasty, but really has no teaching or understanding of what vaginas particularly do. In many cases, the trans woman may have never even seen a cis vagina in person, and certainly likely has not benefited from those typical teachings that we would get from our mothers about yeast infections, about bacterial vaginosis, about, you know, sometimes pain with intercourse, about peeing all over yourself or all over your, you know, all over your bottom, or even about how to wipe. So I use the opportunity to ask patients, you know, how are you adjusting, or have you been sexually active? And then from whatever they answer, we'll go on to the, you know, where that leads me. Or you've been sexually active? Okay, what has that been like? Oh, well, it hurts a lot when I first get started and it gets a little bit easier. Okay, what kind of lubricant are you using? And so on and so forth. And it's worth noting that from just a purely like functional perspective, the neovagina can be sort of considered analogous to postmenopausal woman's vagina. So all the same sort of rules would apply. The tissue tends to get drier. People do tend to get more, in my anecdotal experience, more urinary tract infections. They can get yeast infections, despite there is some conjecture about that, but I've absolutely seen them. Bacterial vaginosis is quite common. It's also worth noting that people who don't know particularly how to care for their vagina, either cis or trans, will put all manner of things into their vagina. I've seen everything from okra to, I don't know if you have okra there, but to help with like lubrication, essentially, because it's very slippery. I've seen people putting in different things to help dilate, and certainly all types of douche stuff. So the guidelines would be the same for a postmenopausal woman, which is essentially nothing but penises, fingers, and trans women do need to douche regularly, which is a little different than the cis population, because they don't self-clean, so tissue that might slough off or just debris doesn't typically exit. So, but I don't recommend anything other than saline water to do it, or even plain water. And once a week is usually sufficient for them. So I just wanted to wrap up now, essentially, that while this population, all the usual rules of primary care apply in terms of like diabetes, hypertension, hyperlipidemia, all those things. The big takeaways here are that there are some special considerations in terms of their risk, specifically related to STDs, HIV, and mental health. As a result of these, the way you will approach and work with the patient will be different, being particularly aware of the prior trauma and how that might inform how they present in your clinic, how they act. As a result, you need to take that into consideration. And it's not to treat them with any kind of special kid gloves, but just the way you would care for somebody who's had a terrible break of their right arm. You wouldn't go maybe as vigorously examining it. You need to consider how they may react to the things you're proposing, and understand where that comes from, and then use that as a way to then move on to another health maintenance item. It's a very gratifying and rewarding population who's desperate for care, has traditionally been denied it, has traditionally not sought it. And so when they can find a provider that gets them, they will be incredibly grateful. And one last parting thought is that for anybody that has any concerns or questions, it's always okay to ask the patient. It's not some taboo, like, I'm not sure, like, how does it work? Do you use your penis for sex, or do you not, like for a trans, whatever it is, you can ask these questions, and the patients will be okay with doing that, as long as it comes from a genuine place of caring and concern. And people are more than happy to explain to you what they've gone through. And then you can really build a connection that I think is durable and provides for good care. So I am out of my 20 minutes already. It went by very quickly, and I do apologize that we didn't have the slides, although they were not super fancy, so I don't think we've missed anything. And I will be available for any questions, and my email is available to everybody who may have additional questions can also email me.
Thank you very much, Dr. Odrzejewski. It was a great talk, and I think it gave a bit of the aspect of the daily life and daily work, which was a very, very important topic to talk about. We had kind of a lot of questions, but unfortunately we don't have a lot of time, so we'll try to address 2 or 3 questions from what you asked. First of all, I want to start with Dr. Wagner, who wanted to ask something also. So Dr. Wagner, can you hear me?
Yes, again, thank you all. It was very nice talks. I learned a lot. I'll do it fast because I really wish we can answer all the questions. So Professor Seifer, it was very interested in the research that you said is going to publish about not stopping estrogen before surgeries. There are some surgeons in Israel that also ask trans men to stop testosterone before the surgeries. So do you do that? And the second question is, what's your protocol for antithrombotic events while you're not stopping estrogen?
Sure. So two things. It was never the case that that there was any logic to holding testosterone. I think it, I don't even know where that comes from. So for certainly that makes no sense. That there's no thrombosis associated with androgens. And then in terms of our protocol, I think we maybe do something like that offline. It's based on Caprini score, just simply the same as we do throughout Mount Sinai for any of our surgical patients. We just simply apply a risk factor, and then we determine whether they're going to have the stockings or anticoagulation in the form of sub-Q heparin. And we're very aggressive. The one thing we're notable about is we are very aggressive about early ambulation. I think people were, especially with the genital surgeries, had tended to have people sit in bed and longer, but with vaginoplasty, we really want to get people moving quickly, like for other surgeries.
Thank you.
Thank you. So I think we'll go over like another 2 questions or so. So one question was for Dr. Reisman. The question was, is breast growth affected by the age of hormone therapy when hormone therapy starts? Like, for example, if it's over 50. So is age matters?
So that's something that I think needs to be studied more, but I think it's really interesting. One of the issues that could potentially be, could contribute, I didn't really go into this, but could limit breast growth is not just age of initiation, but IGF-1 levels. So that would have a couple of different implications. So that could potentially explain why people are under this impression that starting hormones later in life doesn't lead to as robust breast growth. It could also have implications for how we give estrogen, because something like a patch is less likely to suppress IGF-1 levels compared to like oral estrogen. So that may be, I mean, this is like such a stretch, it's not even funny, but that potentially could explain the anecdotal things that we hear floating around about women, transgender women on like injectable estrogen having better breast growth than pills, for example. So long story short, no, but that's a very, very interesting area to explore.
Thank you. And another question to Dr. Safer is about the psychiatric evaluation before surgeries. Is in the United States or in your center, does it have to happen in every kind of surgery, top or bottom, or how does it exactly work?
So it's very insurance company driven right now in the United States. The insurance companies follow the old WPATH SOC7 guidelines from 2011, where for genital surgeries, they tend to want letters from 2 mental health experts plus a medicine expert. And for other surgeries, they want a single mental health person often and a medicine person. But from a surgical outcomes perspective, we're really interested in screening our people for medical concerns and optimizing them for surgery, just like any other surgery, and ability to follow the program. That is, are they going to, do they have stable housing? More of a social work screen, if you think about it. And then the mental health screen is really much more superficial, unless they have mental health morbidity of some sort, which needs to be optimized. So we kind of got several things going on. We're still following that WPATH protocol because we have to, because the insurance companies force us. And then we're trying to do the right thing in parallel for good surgical outcomes.
Great. And another just a small questions, the difference between trans women starting HRT in puberty versus adults. Is there a kind of a difference?
The short answer is if it's peri-puberty, if we're going to use actual hormones, if we're at that stage and we're comfortable with that, then the short answer is no. The hormone regimen, starting in an adult, just simply being the only regimen, or in somebody who's in the appropriate stage of puberty, if they've been on puberty blockers, they could go to a straight adult regimen, or if they're an older adolescent where they're already post-pubertal, they would go straight to an adult regimen, maybe titrated for size.
Thank you very much. And I think with that, we'll conclude the day because we are out of time, but there were still many more questions, and I'm sure the panelists will love to have you just send them by email or something if you didn't get an answer for your questions also. I would like to thank everyone that took part from the technical side, but mostly and most importantly, the people who took time from their day to kind of like take part in this session. And I'm sure that you learned a lot, and that I hope in the future we'll have more than those, because I feel it can be a great cooperation between the two, between Israel and the United States. So thank you very much, and that's it for now, I think.
All right, my pleasure.
Thank you all.